Good afternoon. I'm Dr. Siham M, Department of Medicine, Division of Infectious Diseases at the Howard University College of Medicine in Washington, D.C. I'm presenting on behalf of our group, Dr. Bruno Murad and Dr. Juliana Muniz. The topic is use of antifungal agents in non-neutropenic critically ill patients with decreased invasive fungal infections versus placebo, a systemic review and meta-analysis. The background is invasive candidiasis is considered the third most common bloodstream infection in critical care units and can lead to increased morbidity and mortality. Invasive fungal infections can be deadly if not recognized early in the course of the disease. Reaching a diagnosis can be challenging, making optimal treatment difficult. The controversy exists and has always been whether to treat empirically once there is a high index of suspicion or choose to use a preemptive strategy once diagnosis is made, especially among critically ill patients. The methods we used in this study is PubMed, Scopus, and Cochrane database were searched for randomized controlled trials that compared the preemptive use of antifungal agents in non-neutropenic critically ill patients versus placebo. Reported outcomes were 1. Reduction of the incidence of invasive fungal infections, 2. Mortality, 3. Adverse events. A random effects model was used to pool risk ratios across studies. The results, we included 6 randomized controlled trials. Invasive fungal infections occurred in 23 of 610 patients in the antifungal group and 68 of 590 in the placebo group. The relative risk was 0.35, 95% confidence interval of 0.22 to 0.55. Adverse events were reported in 202 of 378 patients receiving antifungals and 188 of 362 receiving placebo. The relative risk was 1.03 with a 95% confidence interval of 0.95 to 1.13. There were 145 out of 625 deaths in the intervention group versus 132 out of 608 in the placebo group with a relative risk of 1.05, 95% confidence interval of 0.86 to 1.29. The conclusion of our study is that these findings suggest that preemptive antifungal treatment in critically ill patients decreased invasive fungal infections but did not affect the mortality or adverse events. This is our figure 1, the Prisma flow diagram of the study screening and selection. PubMed search was 202 results, Embase search with 378 results, and the Cochrane search was 121 results. The number of studies screened was 701, the duplicate reports were 196, and the excluded by title and abstract were 491. The fully reviewed studies, 14 studies, abstract only was 3, alternative intervention was 2, no outcomes of interest was 1, and other was 2. So we included in our study 6 total studies. We're also sharing our forest plot for new invasive fungal infection. On the far left, you'll find the names of the studies, including the empirical study, which was in 2016. There are several columns here that include the intervention, the control. In each column, there are the events by study and the total number of events, the weight of the studies, the relative risk, and the 95% confidence interval. We also looked at the heterogeneity of the studies, and in this forest plot, you can see that the intervention, the results favors the intervention group. We also sharing here the forest plot for death at the end of the day. Again, the far left to show the intervention in the intervention group with antifungal agents versus placebo, and here death was not affected by the antifungal therapy. The last forest plot shows the adverse events where we have selected a few studies that had significant adverse events where you find the intervention group versus the control group with the number of events and the total. Also, again, the weight of the studies, the relative risk, and the confidence interval. And again, this was not affected by antifungal agents. Take-home points are invasive fungal infection and mortality. Invasive fungal infection can increase the risk of death in critically ill patients, even if they are not neutropenic. Preemptive treatment in this approach, antifungal treatment, is started early, but only if test results or radiologic findings suggest a possible infection. Empiric treatment is defined as the start of antifungal treatment immediately when symptoms appear, even without confirmed infection, example, fever. These study findings in critically ill non-neutropenic patients, preemptive antifungal treatment reduced infections but did not change the risk of death or side effects. Thank you, and I'll be happy to answer any questions.